Hi, good morning, everyone. We'll go ahead and get started to stay on time. I am Courtney Schuss. I'm a professor of neurology, vice chair of education at Barrow Neurological Institute in Phoenix, Arizona. We have a few housekeeping announcements before the presentations. So we'd like to welcome all of you, welcome the virtual audience. Please remember to silence all of your mobile phones. You can access the program materials through the AAN Conference's mobile app. Apparently, they're not all up now, but we'll double check to make sure that they are hopefully up after the session. There are translation and transcription services that are available on the mobile app and the online platform. You can either scan the QR code that was in the walk-in slides or navigate to the session in the app itself. And if you choose to use the audio translation option, please be sure to use headphones. An evaluation must be completed to receive CME credits by May 7th, 2025, and they're all available again in the conference mobile app or online. And the AAN strictly prohibits all unauthorized photography, audio, and/or video recording of any kind in programs. There is an online Q&A for this in the mobile app. We will have a Q&A session in person at the end of this, and we'll also answer any questions in the app as well. So it's my pleasure to introduce our first speaker this morning, Dr. Courtney Westhoff. Dr. Westhoff is Chief of Child Neurology, Program Director for the Child Neurology Residency Program, and a Professor of Neurology at UC Davis Health. Her clinical research focus is on neonatal neurology and critical care EEG. And she'll start us off looking at what's new for management in kids with epilepsy.
Thanks very much. Thank you, everyone who's here with us in person this morning, especially out in the far reaches of room 3. Thank you to everyone who's watching at home. I'm going to talk about what's new for kids with epilepsy. I think a lot of folks take care of both kids and adults with epilepsy, or you might every now and then have a pediatric patient. And there has been some exciting stuff that's been coming out. So I'm going to hit some highlights from the last couple of years, hopefully some stuff that'll be useful for your practice. I don't have any disclosures relevant to today's talk. I am going to talk about some off-label use of anti-seizure medicines because most of what we do in neonates is off-label. Here's what I'm hoping that we'll accomplish today. We'll talk about neonatal seizures because there's been some changes to the standards for diagnosis and treatment of neonatal seizures. I'll talk about pediatric epilepsy syndromes and some of the new nomenclature that's been coming out around those. I'm going to touch on infantile spasms, where I think we have some more data than we have had in the past to guide practice. And we'll talk about rescue medications and quality of life in kids with epilepsy. All right, so we'll start out from the beginning with the newborns. What's new with newborns? So this is a couple of years out now, but I think is still starting to take hold in implementation. And there's been a shift, a paradigm shift in how we think about newborns with seizures, neonatal seizures, and what's required to diagnose them. So a couple of years ago, the way that a newborn who had seizures would be sort of classified, or you would talk about the diagnosis, would be to focus on the semiology. And so you would have all of these terms that were designed for adults with epilepsy, and you would try to pigeonhole a newborn into them. And it doesn't quite work, because I'm not sure what a gelastic seizure would look like in a neonate. And so fortunately, that nomenclature and that classification system has been abandoned for neonates. And instead, the International League Against Epilepsy came out with a new classification system. And this is also at the same time an algorithm to walk you through diagnosis of neonatal seizures. This was published in 2021 by Ronit Pressler and colleagues. And it's a really nice approach because it focuses on the certainty of the diagnosis. And so what you start with is a baby where you think they might be having seizures. They're doing a funny movement, they have some lip smacking, they're sick, so you know they're at risk for seizures. And you can say, well, they did their thing. How am I going to make that diagnosis? If there's no EEG available, then it depends on what the baby's doing and who saw the baby do their thing. The most common, if there's a clinical sign for seizure, the most common type of clinical seizures in newborns are clonic seizures, that 1 to 3 per second contraction of a muscle group followed by a slower relaxation. It's rhythmic. And so a focal clonic seizure is going to be the most common clinical seizure type in a newborn. If you see anything other than that, maybe it's a seizure, but maybe not. Babies do lots of weird stuff. They have funny twitches and jerks and mouth movements. And it also depends on who sees it. If you've got that NICU nurse who's been doing this for 15 years and she says, yeah, that was a seizure, probably that's more certain than the new person, the maybe caregiver who's never seen a seizure, or someone else who happens to see a funny movement. And so if you have both that best possible clinical sign and the most experienced observer, the best you could do would say that's a probable seizure. So an experienced healthcare professional who sees clonic jerks at the bedside and thinks it's a seizure, probably a seizure, but not definitely. Anything short of that is either a possible seizure or just insufficient evidence. And this is different than what we've had in the past, where people would make a diagnosis of neonatal seizures by looking at the baby and saying, yeah, I think that funny twitch is a seizure. If you don't have EEG available, best you can do is probable seizure. The gold standard for diagnosis of neonatal seizures is continuous EEG monitoring. And so if the baby does their thing and they're on EEG, great. If it's not a seizure on EEG, it's not a seizure. If it's a seizure on EEG, it's a seizure. Makes it easy. There are two types of seizures. Now, again, the classification has gotten much simpler, where it's either a seizure that's electrographic only, meaning you can see it on the EEG, but you can't see it from the bedside, or electroclinical, meaning you can see the EEG seizure at the same time as the baby's doing their thing. Most neonatal seizures are electrographic only. About 85% of the time that a baby spends having seizures, a newborn, it's gonna be electrographic only. So you'll never tell from looking at the video. And this isn't just like, oh, if they were looking closer, they were more experienced. It's when you chain the poor fellow to the computer and say, look at this video and tell me when you see the clinical signs that go along with the seizure, there's just nothing there. Now, how many people have heard of amplitude integrated EEG? Okay, a couple. So this is a tool that is increasingly used by neonatologists. It's a reduced array EEG, usually 4 electrodes, central and parietal, or maybe even frontal and central. And it's marketed directly to neonatologists as a bedside tool to do brain monitoring. So you don't have to deal with those annoying neurologists to get your answer about whether or not there's a seizure. It's better than nothing, absolutely. It gives you some information about what's going on in the brain, more than just looking at the baby and guessing, is it a probable seizure? But as you can imagine, 4 electrodes is not the same as a full array EEG. And the bedside display that comes out is really just looking at the amplitude over time. It gives a trend, a quantitative EEG of what's happening over usually a 3-hour period. So it's not as good as conventional EEG. So if you think the baby's having a seizure, and you put the amplitude integrated EEG on, and there's no seizure, it's still insufficient evidence. You cannot exclude seizures with AEEG. If, however, the baby's doing their same thing at the same time as the AEEG is showing a pattern that looks like a seizure, then it's a probable seizure. There's still a lot of artifact. There's a lot of false positives with the amplitude integrated EEG, so you can't be certain. But if you're, for example, in a situation where you don't have EEG readily available, you might be able to get closer to diagnosis with AEG. So this is the new framework, the new classification system for neonatal seizures. Semiology is de-emphasized, and it's really about how are you making this diagnosis and what's the certainty of the diagnosis. And I think as neurologists, we're going to hear more and more about this because neonatologists are starting to recognize that if they're worried about seizures, they have to have the EEG to make definitive diagnosis, and then that's where we'll often get involved. More details about this can be found in the ACNS, the American Clinical Neurophys Society Guideline on Indications for Continuous EEG Monitoring. This was just updated this year. And what we did is we took a look, we did an evidence-based guideline, clinical practice guideline, to take a look at who are the groups of newborns who are at highest risk for seizures. And we found that overall there's a range of different risks for different populations. But if you look, for example, at babies who have hypoxic ischemic encephalopathy, who are receiving cooling treatment, anywhere from about 20 up to half of them are going to have seizures in the first 72 hours. And so at many centers, that's a population where if a baby comes in, they get hooked up to EEG monitoring right away, rather than waiting for that first twitch or funny movement because they're at such high risk for seizures. You can see the range for other groups here. I'll just point out inborn errors of metabolism. If you have a baby where you suspect an inborn error of metabolism, they're at a pretty high risk for seizures and might be worth considering some screening EEG as well. So once you've diagnosed the seizure, what do you do with it? This is an area that's still got a lot of controversy in it. Neonatologists yell at each other at meetings. But there is now a guideline from the International League Against Epilepsy about how do you treat seizures in the neonate. And it's because we finally have some evidence to guide us in this. For a long time, the answer was phenobarb, because that's all there was. You could have phenobarb or you could have phenobarb. And unfortunately, it's the drug we love to hate. It is still the first-line anti-seizure medication because it has the most data to support it. And my next slide will talk a little bit about that. That's regardless of etiology. Once you get to second-line treatment, there's not great evidence to steer towards one or the other. But one thing that's new that I think is a change in practice for a lot of folks, and certainly for a lot of neonatal intensive care units, is that if a baby has acute symptomatic seizures, meaning you know why they had a seizure, it's a temporary thing that happened to them while they're in the ICU, maybe it was HIE, maybe it was a stroke, those babies have their seizures along with their acute injury or illness, but then most of them do not go on to have epilepsy. Overall, it's fewer than 15% who will go on to have epilepsy. And there was a comparative effectiveness study that showed that if you stop their seizure medicine, like their phenobarb, before they go home from the NICU, it doesn't do anything to change their risk of having later epilepsy as compared to those babies who were kept on medicine for months or years after discharge. So if it's not helping to keep them on the medication after they go home, and obviously phenobarb has some nasty side effects, it is increasingly becoming that practice to discontinue anti-seizure medicine for acute symptomatic seizures once the seizures have been controlled, baby's getting ready to go home, and that way they're not being exposed to a medication which isn't necessarily helping them in the long term. So that's part of that guideline, and I think that's another thing where we're starting to see a shift in practice. If you get called and asked to take care of newborns, that's something you might get asked about if you see them in your clinic after they've been discharged. We do now have some evidence to support that it's safe to discontinue medicine earlier than folks did in the past. So what about that phenobarbital recommendation? We hate phenobarb, it makes them sleepy, it hurts their respiratory drive. Can't we do better? Unfortunately, the data that we have doesn't show that there's a better alternative yet. The best evidence that I think we have of a trial that went head-to-head was NeoLEV-2. That compared levetiracetam to phenobarbital, and I think to the surprise of everyone involved, it showed that levetiracetam was much less effective than phenobarb for neonatal seizures. It was a really well-designed study. It was a crossover study where babies who were at risk for seizures, for example, babies with HIE or babies who had funny movements, got hooked up to EEG before they received any treatment. Once seizures were confirmed by EEG, they were randomized either to levetiracetam or to phenobarbital. And if they were still seizing after they maxed out their dose of one drug, they crossed over to the other. And what the study found is that really looking at any endpoint, phenobarbital outperformed levetiracetam. So the primary outcome was once you got your med, you got a full dose of your med, what was the chance of your seizures staying controlled for at least 24 hours? And you can see the babies who had phenobarb, 80% of them had seizure control for 24 hours. The babies who got levetiracetam, it was 28%. That's a pretty big difference, with an odds ratio getting close to 10. And that finding held no matter how you carved out the results. What if we wanted to see who was seizure-free for 48 hours? It's still phenobarb. What about the 1 hour seizure freedom? Still phenobarb. What about just the babies with HIE? It's still phenobarb. So I think sort of disappointingly, but helpfully, this study showed that phenobarbital is more effective than levetiracetam. And that's the evidence basis for this now international recommendation that it's your first-line treatment for newborns who have seizures. And again, that guideline also relies on the evidence that we now have that if a baby has seizures, you know what the cause is. You do want to control the symptomatic seizures. You want to make sure the baby's seizure-free for at least 24 hours. In my personal practice, I'll give them at least a couple of days of seizure freedom till they've gotten out of that period of acute injury. But knowing that the vast majority of babies aren't going to go on to have postneonatal epilepsy, we don't want to keep them on medicine that they don't need. And so that was this study that I mentioned, led by Hannah Glass and Renee Shellhouse, the neonatal seizure registry study, which looked at safety of stopping anti-seizure medicine for newborns before they left the NICU. And what they found was that if you stopped the medicine early, it did not increase your risk of having postneonatal epilepsy or seizures after going home. It was still overall about 13% for the whole cohort. And so for that reason, it's now standard of care, standard practice to stop that seizure medicine before babies leave the NICU. All right, moving out of the neonatal period into later childhood, I think something that's worth being familiar with, if you haven't already gotten used to this, is that some of the names, the nomenclature that's used for some of the pediatric syndromes has changed. I still slip all the time, but I'm trying. So, of course, anti-epileptic drug, anti-seizure medicine, because we're not treating, unfortunately, we're not able to cure the epilepsy with most of the drugs that we use. We're trying to prevent the seizures. So you'll see ASM in place of AED. The ILAE came out with a slew of papers talking about classification and definition of epilepsy syndromes in childhood. I think the good news is that the types of syndromes haven't really changed from what you might already be familiar with. The part where you might stumble, or at least I do, is in trying to remember the new names of the syndromes. So there are now these three big categories of childhood onset epilepsy syndromes. There's the self-limited focal epilepsies. Those used to be called the benign epilepsies, and that got changed because it's not really benign to have epilepsy. It's not nothing, but self-limited in the sense that they're not going to persist endlessly into adulthood for most kids. What used to be called benign relantic epilepsy is now self-limited epilepsy with centrotemporal spikes. So if you just got used to calling benign relantic epilepsy, epilepsy with centrotemporal spikes, you're close, but now it's SELECTS. Paniatopoulos syndrome is now self-limited epilepsy with autonomic seizures, or CELES. Then you've got your generalized epilepsies, childhood absence epilepsy, it's the same, yes. Javon syndrome is now epilepsy with eyelid myoclonia. And the third category of childhood onset epilepsy syndromes are the developmental epileptic encephalopathies. And so these are the bad epilepsies. These are the ones where you got the epilepsy and also the epileptic activity is causing an encephalopathy. It's contributing to impairment. An example of that is, no one knows, dozes, no one knows. People in the room will tell me I'm wrong either way. That's now epilepsy with myoclonic atonic seizures. There's also a number of other ones that have names in the paper if you want to go to it, but these are the ones that I think we most commonly encounter and the nomenclatures that it's worth trying to get familiar with because people will increasingly be using them. I'll talk a little bit more about developmental epileptic encephalopathies with spike wave activation in sleep. So this is what formerly was known as ESIS, electrical status epilepticus in sleep. And it's really that range of epilepsies where what they have are spike waves that are activated in sleep. They also have developmental regression. And it used to be called ESIS because they would have spikes in like over 85% of sleep, but it's not really seizures, it's spikes, and so that's part of the reason for the name change. The key feature here is that the recognition that regression can happen even if you have a lower, spike burden than 85%. So it's not magic. It's not that 84%, you're cool, 86%, it's all over. There's really a range, and it's going to be different for different kids in different situations. There's not yet a standard number that's been universally accepted. It's rather that if you have a child who had normal development, you get this EEG pattern in sleep, and they have regression, then you should be suspecting the diagnosis. Even in a child who has developmental abnormality, if you find this pattern in sleep and they're having a neurodevelopmental disorder that's getting worse, then you should be thinking about this diagnosis. So the D is if they have already developmental abnormality, otherwise it's just EE-SWAS. And this is a figure that sort of conceptualizes all of it that's from a paper from 2022. You can have some kids who have no developmental encephalopathy. For example, the Selects used to be Rolandic, Celius used to be Paniatopolis, and some of the other childhood epilepsies. But then you also have the kids who are on the other side of the spectrum, where they may have market activation during sleep, and that's causing them encephalopathy. The one eponymous syndrome that still gets the name is Landau-Kleffner. These are the kids who have language problems that arise with their activation in sleep, their abnormal EEG in sleep. So again, you still have the things that we know from before, but just thought of in a different way, conceptualized in a different way. I'm going to talk about infantile spasms because this is one of those diagnoses that we all have to know, even if you only see a kid once in a blue moon. It's that can't miss diagnosis, and I think we do have some evidence that's changing how we approach it. Also has a name change. It's not infantile spasms anymore. It's infantile epileptic spasm syndrome, IESS. Same thing, different name. And what happens clinically, of course, these are the kids who have this chaotic, high amplitude EEG pattern. It looks the same upside down as right side up. When they're awake, they'll have their spasms often on arousal, and then they might have relative normalization of the EEG after that arousal. When they're in slow wave sleep, they'll have more spiky discharges. The pattern is more likely to become periodic, and they may have those attenuations or almost decrements that are easier to find on the EEG. And when they're in REM sleep, the hypsarrhythmia is reduced or even gone. And I think this is something that's changed practice, because if you only do an EEG where the kid's awake, you're gonna miss kids with this syndrome. If you look at all the kids who have infantile epileptic spasm syndrome, hypsarrhythmia is going to be present in only about 2/3 of them while they're awake. So when you get that call of, hey, I'm sending you this kid, I'm worried they have infantile spasms, you get the EEG. If all you get is that routine EEG, 30 minutes, 60 minutes, they're awake the whole time, they're crying, they never fall asleep, you can't rule out infantile spasms on that basis. You have to either capture the spell of interest and see their movement and say, oh, great, we got it, that's definitely not a seizure. Or you have to capture a full sleep-wake cycle, do a several-hour recording to exclude the diagnosis. Likewise, once you make the diagnosis, you can't rely on that short EEG to assess whether or not the treatment is working. And this paper just came out last year looking at kids who had infantile epileptic spasm syndrome, got their treatment, and then had follow-up EEG. And at this particular center, they did 24-hour EEGs for all of these kids as standard practice to see whether or not they had controlled the hypsarrhythmia. And so then it was a great study because they looked at it and said, well, what if we had only done a 1 hour? What if we had only done a 4-hour EEG? And what they found was that if they just did that 1 hour again, they would have gotten the wrong answer for a good number of kids. They would have thought that the spasms were under control, even though the hypsarrhythmia was not. If you do a 4-hour EEG, you'll catch about 77% of the kids who are still having spasms and 84% of the kids who are still having hypsarrhythmia. And a 24-hour EEG, you're going to catch more than 95% of them. And so the take-home message here is that if you have a kid, you're worried about infantile spasms, you gotta catch slow-wave sleep to exclude the diagnosis. If you hook them up and in the first couple of seconds their EEG looks like that, you've got the diagnosis. But otherwise you have to capture their thing, their clinical event, to know for sure that it's not a spasm, or you have to record for long enough, usually a couple of hours, to get that slow-wave sleep to know that they're not having hypsarrhythmia. And I think this is really a shift in practice, where even a couple of years ago, most people were just doing 30-minute, 1-hour EEGs to answer the question, and unfortunately, that's not enough. More and more you'll see for kids who have infantile epileptic spasms, the BAST score in the EEG report. This is something that's increasingly used. It's not required, but I see more and more of it when I'm getting kids referred into me, and so I think it's worth being familiar with. This is trying to get at that problem of if it's just florid hypsarrhythmia, people agree on that. If it's normal, people agree on that. But sometimes you get the modified hypsarrhythmia. Maybe it's more prominent on one side than the other. Maybe it's got an alternating pattern, where people would sometimes quibble about, like, is that bad enough to be hypsarrhythmia, or is it just bad but not hypsarrhythmia? And so this is a scoring system that uses formal criteria to try to put a score on the EEG, and you can see the criteria there. And here's some examples of it, where if you've got an EEG that's definitely not hypsarrhythmia, people agree on that. And when you've got something that's quite bad, people agree on that. And this score helps to try to come up with something reproducible for the in-between EEGs and how you might score those. It is really helpful when you're looking at response to treatment and you're trying to see if you're headed in the right direction. So this is the reference, and I do think it is a useful system, particularly if you take care of kids frequently. All right, so once you make that diagnosis, how do you treat them? We now have pretty clear evidence that first-line treatment needs to be ACTH, high-dose pred, and or vigabatrin, regardless of etiology. Even if the child has some sort of underlying neurologic problem, they are going to do better with one of these 3 treatments than if you put them on valproic acid or topiramate or some of the things people would try that were less risky than some of these first-line treatments. Well, they're less risky, but they're also far less effective. So if you're going to treat with one of the first-line treatments. The American Academy of Neurology child neurology quality measures, if you use these in your practice, this is one of those things that they track. They say, of patients who you've seen who have infantile epileptic spasms, how many of them got one of these treatments within a week of confirmed diagnosis? Because there's strong enough evidence that this really is what you should be doing. You got to treat quickly, and so that's become a formal quality measure. I think something to be aware of is that there is evidence that there's disparity in who gets the first-line treatment, who gets that standard of care. Fiona Baumer had a paper that came out a couple years ago that showed that as compared to white children, black children were more likely to get inferior treatment options. So really anything that's not one of these first-line treatments. And it wasn't exclusively related to socioeconomic status, it wasn't insurance status. So I think that that's just a bias to recognize and sort of think about in ourselves as we're treating our populations. Are we treating everybody in the same way? All right, moving on to older kids even, children. Benzo rescue meds. This is a place where we've had some more options available, which is great for families. And again, this has become a quality measure for taking care of kids with epilepsy. So the goal, of course, is to give families something that they can have on hand at home should there be that prolonged seizure so that they can stop the seizure without waiting for EMS or going into the emergency department. And the quality of care measure is of the kids who you have who have had prolonged seizures in the past, how many of them have a rescue med prescribed to them at home? And the group we're talking about here are kids who are 6 months and older who have ever had a convulsive seizure longer than 5 minutes. So not the kid with absence seizure. They don't necessarily need to have a rescue med at home if that's the only kind of seizure they've ever had. But if your patient has ever had a convulsion longer than 5 minutes, it's worth talking with the family about what they can have as a rescue med at home. Lots of different options that are available, and again, available for kids as young as 6 months, which has not been the case necessarily in the past. In the hospital, you've got some options that are listed up at the top there. When you're talking about sending something home with families, often this is dictated by insurance. I have some families where they have to have the rectal diazepam. I have some families where they can get the intranasal medications. Generally, the older kids, as you can imagine, the families prefer the intranasal to the rectal. But lots of different options out there for lots of different age groups. So we do now have at least things we can prescribe to meet what we're trying to measure with this quality measure. And I'll finish up with some myth busters, things that impact quality of life. Some of this is new in the last couple of years. Some of this is things that we've had more and more information about for longer than that, but certainly generational. If I think about things that I learned as a resident about epilepsy and things that we know about now, where we've had a change in thinking. So I think a big one is seizure safety precautions. For kids with epilepsy, the goal is going to be to remain as active as possible. When you look at information, and this is older data, this is from 2012, but it's still the case, unfortunately, children and youth with epilepsy are less active than their peers. They are far more likely to report limited activity than their peers. And obviously, this has all kinds of problems that goes along with it. If you're not being active, if you're not physically active, there are secondary health problems that go along with that. It increases the social stigma. You can't participate in the same stuff as other kids. It has emotional and psychological detriments. And so with seizure safety precautions, I think it used to be back in the day, they're like, no, they can't do any sports, they can't do PE, they can't go to camp. And that ended up being the thing that parents reported was disabling. When you talk to families and people with epilepsy about, well, what makes you feel like you're disabled? It's not necessarily the seizures, it's all of the restrictions that were put on someone because of that diagnosis of epilepsy or because they have had seizures. And often those restrictions are way more than what's medically indicated. The perception of disability is much higher if the restrictions are recommended by a doctor or if the family perceives that the doctor thinks the restrictions are a good idea. And so, of course, there's a trade-off, right? There are some things you should not do. You should not go scuba diving if you have epilepsy because you could have a seizure and die. You can't go skydiving by yourself, but you can do tandem skydiving. I always say if your parents let you. You can go swimming. You can be in that body of water, but you have to have someone within arm's reach who's going to be able to help if there's a seizure. You can do PE, you can do PE. All of these things that used to be completely off limits, I think you can have a more nuanced conversation so that kids can participate in all of these really important activities. So it's that again, discussion about personal safety, recognizing what's the stuff that really is off limits, versus all of the stuff that you're going to miss out on if the restrictions are too draconian. So what are some seizure safety precautions you still have to stick with? Swimming in baths, only with a close adult supervision at all times. So if they take baths for the little kids, they gotta have an adult in the room. At some point, they're gonna wanna switch to showers, so they don't have an adult in the room. You can take your shower by yourself, but can't be in that body of water, that bath. Same thing for swimming, but they can go swimming, as long as there's somebody who's doing one-on-one supervision. No climbing to heights. You're not going to be doing free rock climbing without any kind of harness or anything. But they can still do rock climbing at a gym as long as they have the belay, that sort of harness with them. They can participate in that. I'm not letting my kids free climb anyway. Helmets, you can ride a bike. You can go skating, wear a helmet. You might fall off your bike. Anyone might fall off their bike. So again, it's sort of thinking about for that child, what's that trade-off? I always do, of course, talk about caution around fire, stove, surfaces, and I explicitly tell families, you do not have to sleep with your child with epilepsy in the same bed or the same room, because especially after the diagnosis happens, this is often the reaction is people are terrified there's going to be a seizure at night, they have the kid come into bed with them, and then nobody's sleeping. Mom's not sleeping, kid's not sleeping. Kid may be having more seizures now because they're not sleeping at night. Parents are a wreck because they're not sleeping. Nobody wins. So I do say explicitly, they don't have to come into your room or your bed. You can get a monitor, you can get a baby monitor, lots of other solutions. For things like sports, again, kids with epilepsy should do sports. Sometimes you gotta have the parents talk to the coach, make them aware, but contact sports are okay. There's no evidence that these induce seizures. All of this other stuff, you might have to have some kind of accommodation or supervision, but there's ways to do it. There are few no-nos. Again, free climbing, solo skydiving, solo hang gliding, and scuba diving. But really beyond that, there's a way to do most of the things that kids are gonna wanna do. So here are my take-home points, starting with the youngest ones, with the newborns. EEG is the standard of care for diagnosis of neonatal seizures. If you diagnose seizures, phenobarb is still the first-line treatment, but at least we now have evidence to show that we can stop that medicine if you know that they're acute symptomatic seizures before the kid goes home. We got lots of new nomenclature. Good luck. We'll all do our best. Eponyms are on their way out, descriptive names coming on their way in. Infantile spasms, you can't rule it out without a prolonged EEG. You gotta capture slow wave sleep. Once you make that diagnosis, you have to do the long EEG to reassess whether your treatment's working, and there are 3 first-line treatments for infantile epileptic spasms. Anything else is inferior. We've got more options for rescue meds for kids, and hopefully we're able to help encourage them to have full lives with as few restrictions as possible. I'll wait until the end for questions, but thanks, everybody.